some high-level topics, and then we can address any questions that everybody has. I'm going to put things in perspective at, let's say, the international, national level, and then more at the local level. And they're very different. And I will tell you, although I'm not a fan of how the media has been covering this, there's a lot of good things that they've covered, a lot of good facts, but I don't think they present things in a very concise and a very helpful manner some of the times. So COVID-19 is one of the SARS viruses. It's the third one that we really have been dealing with. The first two was basically, they both, well, one was in China, and that was the first one that we knew about, and that was SARS, and that really never escaped that country very much. The second one was the MERS virus, and that was in the Middle Eastern area. That's why it was called MERS, Middle Eastern respiratory. And now this one is COVID-19. The 19 is because it came out in 2019. That's when it was discovered. So it's not the 19th strain, actually. It is a coronavirus. There are a lot of coronaviruses out there. And coronavirus, in most people, causes the common cold. Not this variety of coronavirus, but the one that's been around for forever. So just because you have a coronavirus doesn't mean that you're going to get very sick. There's a lot of things that will cause common colds. This is definitely one of them. So the outbreak, as far as we know, really started in China. There's really a debate as to how that started. We don't know whether it crossed over from the animal realm into the human realm, which has happened before with viruses, or if some of this was a genetically altered strain that then escaped the lab. I think in the end that may be helpful to know, but for right now, it's actually meaningless because it's already out there. So instead of trying to figure out, although I'm sure there are people trying to figure that out, instead of trying to do that, what we have to do is deal with the circumstances we're dealt with today. And that's that we have a virus, and viruses spread fairly easily. This is not, in perspective, the most contagious virus by any stretch out there. So if you want a little historical perspective here in terms of viruses and how dangerous things can get, there's really two ways to look at it. One way is how sick does something make you? The other is how contagious is something? This is going to sound a little odd, but a virus's job is to replicate. A virus needs a host. It is by itself not a living organism, so it either needs a bacteria, animal, humans, something to replicate. It needs that source, and it needs that DNA or RNA to help do that. Bacteria can grow on their own. They can live somewhere on a surface. They can live forever if it's in the right environment. Viruses cannot do that. They may go dormant, or eventually they just die off on surfaces usually. So the most efficient virus does not kill very well because otherwise it can't replicate. Probably one of the biggest viruses that gets a lot of play is Ebola. Okay, it's a horrible virus, and we hear about outbreaks mostly over in Africa. It's a very deadly virus, but it's not a very efficient virus for a virus because it kills people too fast. I know that sounds awful, but what that means is it can't spread very well. Okay. On the other hand, you have other viruses like polio and smallpox. Yes, they've basically been eliminated, at least from the United States, they've been eliminated. And they don't kill you. They maim you. They take a long time, but they're very good at spreading. Okay. But they don't kill somebody very rapidly. Yes, people die from all different diseases and viruses. Now, those have been eliminated because we have effective vaccines for them, especially in the United States. Where does this virus fall? This virus basically falls, it's a little worse than the seasonal flu. in both how contagious it is and also in its impact and how deadly it is. So it's getting a lot more play than that. It's being a lot more impactful, and one of the reasons for that is that we don't have a vaccine. We do have a vaccine for the seasonal flu. And so because of that, and even though I will say, and everybody will agree to this in the medical community, our flu vaccine is not the best vaccine we have out there by any stretch. In a good year, it's going to be 50 to 60% effective. However, year after year after year, not all the strains change. And you do tend to build up more and more immunity. So it does tend to still be very effective. And you don't see, although you see outbreaks of flu, you don't see it impacting society quite as much as you are seeing this right now. So this virus spreads, it spreads by respiratory droplets. So that means when I'm speaking, when somebody sneezes, coughs, and they aerosolize what's in their lungs, it spreads that way. So the further away you are from somebody, those respiratory droplets will drop to the surface on their own, okay? Assuming still conditions, you're not standing outside and there's not, 40-mile-per-hour thunderstorm winds right now going on, all right? So when they bring up masks, that's how masks help. So masks, you're putting something in front of your face and blocking where this is going to go, and the mask is going to catch the majority of it. It's not going to catch 100%, but it is going to catch the majority of it. Like, masks have been used forever. We use masks when you're in a surgical suite. And outside of COVID time, the typical surgical masks we use are very, very effective. That's one way that we actually prevent giving infections to the surgical, the person being operated on, okay? And in fact, what was always odd, in when you're in medical school and you're in different rotations, you learn if you're going to sneeze in surgery, which is obviously discouraged, but go and stop yourself if you really have to. It may not happen. You actually face the patient and sneeze that way. Okay, and the reason is the mask will protect the patient. And if anything's going to get out of the mask, it's going to be the sides of the mask, right? Where most of our instincts, especially if you're not masked, would be to turn or to sneeze into your elbow. And sneezing into your elbow is very good if you're out in public and you're not wearing a mask for other times. That's actually the most effective. Better than covering your face with your hands or anything else, or even a tissue, okay? But in surgery, you actually sneeze straight into the mask because it is the most effective. So we do know that there's a lot of data on that. There's data for coronavirus also. And the thought is the more people that wear masks, the less that you're going to have floating around and floating between people, and the larger the distances you keep. And it's also a matter of time. It's a matter of exposure. Any disease is a matter of how much are you exposed to and for how long. So when you're outdoors and there's good airflow, by definition, that's different than being in a room where the doors may be always closed and there's not circulation of air coming into the room and air being taken out of the room. So you have that in the hospital and surgical suites, and you have that in patient rooms. You don't necessarily have that everywhere that you go and in workplaces. It just varies from workplace to workplace and home to home. Is your cold air return in your bedroom, or is there not one? If there's not one, you don't have that circulation. So now what you're waiting for the virus to do is actually settle down. So internationally, there have been a lot of different strategies on how to control this. And you'll see that in the news. Some will try and shut down the entire country, and others have said, you know what, we're just going to let it run through the country. We're going to advise that we try and keep the nursing home and the older people and the people who are immunosuppressed safe, and do your best to stay away from those people if you're ill or just in general. That was really the approach that Sweden took. Sweden had a huge increase right away. They probably had more deaths than they admit to this than they needed to, because people probably weren't as careful in the nursing home environments and with that and with the more risky population. But they peaked and they came way down, and right now there's not any signs of another huge peak there. Then you have other countries that have totally shut down and they've slowly opened up. There have been different challenges in different countries. So Italy, the biggest challenge that we had, that they had, was really their facilities. It was the rate at which the virus hit them, but it was also the fact of what their facilities could handle. So you're going to have different challenges in different countries. Our approach in the beginning was to try and not overwhelm the healthcare system. So remember, when the strategy was announced, and without being political at all, when the strategy's been talked about by all the different people, it's also it's really to not overwhelm the healthcare system, to make sure that we have enough hospital capacity, enough ICU beds. Now, that was obviously in the beginning a challenge for New York City. There's quite a density of population in New York City. And although they have more hospital beds there than obviously we have here in Wausau, not a surprise, they don't necessarily have more per 100,000. And you've got a very dense population, right? So everything there are high rises. I'm not saying there are no low rise buildings, right? But everything in the city proper really are high rise buildings. And it's very impractical to keep people apart, even if you're wearing masks. Now, remember, what a mask does is a mask helps prevent you spread it to somebody else. It doesn't help you from getting it if it's out there, because the mask, a typical cloth mask, is not filtering. Okay, if you want something to protect you against that, then that's an N95 mask that has to be properly fitted, which I can't wear if I have a beard. You can't properly seal that off. So you can go to the wear a papper, which is basically a big hood, if you're going to be in that type of environment, and that will protect you because that has actually filters, different filters on it. So you're wearing a mask to help prevent the spread should you have it. You're not wearing a mask ever to protect yourself, which I saw was actually one of the questions here. So in high density populations, you have a really hard time controlling this. I was one day listening to CNN, and one of the persons on there was talking about what's going to happen in the fall and what people need to do, and that if you're in a high rise, you really need to spread out 6 feet. And I don't know if that person's ever been in a high rise elevator, but most elevators, you don't have 6 feet between you. Even if you go to opposite corners, that's a pretty big elevator. That might be a freight elevator in those. And they said, well, you should take the elevator alone. Well, that's really not practical, because when you have 600 to 1,000 people living in a building, and you have to go to work and come back from work, you can't wait 3 hours each time to just take the elevator. And then the poor sucker who's on a lower floor is never going to get an empty elevator car, because whoever starts at the top is going to be lucky. If you're starting at the bottom, again, you're going to have this long line. So certain things just aren't practical in certain situations, and we have to contend with that. The data says right now that children do not get as ill as adults. That doesn't mean that no children get ill. And what we're doing is we're talking about children that have normal health. We're not talking about special circumstances where children may be fighting off their own cancers, leukemias, or have other immune suppressed systems for other reasons. Okay. In general, when we talk about what's going on, we're talking about people of average health. Okay. There are certain higher risk diseases, both in children and in adults. So anything that affects your respiratory system will make you a higher risk for COVID. COVID is primarily a respiratory disease, and that's how it's going to really hit somebody the hardest. Now, look, people are going to be really achy with COVID. They can run a fever with COVID. Not everybody runs a big fever. There are people who aren't running much of a fever, and there are people who have no respiratory symptoms at all. But they're achy to the hilt, and they feel like a truck ran them over, and that can last for a really long time. But if you have asthma, if you have COPD, if you have a pulmonary fibrosis or other respiratory diseases, then it's going to be very difficult for you to fight this off, or more difficult. Doesn't mean you're not going to recover, but it means that you're at a higher risk. So people who have other pulmonary diseases, there's people who are obese, people who have uncontrolled heart disease, heart failure, and uncontrolled diabetes are going to be more at risk. There's not a good way to stratify everybody's risk to say it's this percentage higher and that. A lot of it depends. Why did you see healthy healthcare personnel die? Some of the theories behind that, and we don't know, there's a lot to be learned here, is that they're exposed to more of it in general. They may actually get a higher inoculation of it from the people that are sick and from multiple people that are sick. In the beginning, a lot of them may not have taken the care that needed to be done, not because they were negligent, but we may not have known that they need to do that. Some people were upset. I've seen lots of patients December, January, February that I thought, wow, now in retrospect, did they have this? Did it start here sooner? And I've tested some of them with the antibody tests. And actually, personally, I've not found anybody who's had it. I've been a little disappointed in that because I thought some of them really were a good scenario for it. Are antibody tests effective? Are one of the questions that leads into that. So they are effective. The ones that we're using in Aspirus, they get turned around in under 24 hours, and it's 99% sensitive and 99.5% specific. So it means it's a really good test. However, if you do not have a high incidence or high prevalence of the disease in the community at the time, you're likely not going to find very much of it, and you're likely going to even potentially have some possibly have some false negatives, not false positives, right? In other words, people are going to test negative that maybe had it, but they didn't have a bad enough case. So really, if you look at Marathon County, I mean, the numbers are going up. I haven't looked at today's numbers. But our rate of infection is very low per 100,000 people. We've had, a few hundred cases. Of those, almost all of them have been at home and recovered at home. The one death we had in Marathon County that I'm aware of was somebody already enrolled in hospice. And that's where you get a little sticky here. And I don't have a good answer for it. And what I mean by that is that, how do you count that person's death? Did COVID influence their death? The answer is yes. Did they die sooner? Probably because of it. I don't know the case personally. The answer is probably yes. Is that very unfortunate? Of course. Was this person going to die soon anyhow? The answer is yes. However, that's going to get listed as a COVID death. And that's not necessarily a big deal here. It is a big deal statistically when you start looking at cities like New York. And I'm in some chat groups where it's physician only and have to be vetted in. And the people on the front lines in New York have said almost everybody who's really not doing well and seriously hospitalized are in their 70s, 80s, and 90s with a lot of other health conditions that aren't making it through. And that's extremely unfortunate. It'd be great if we could prevent that. But a lot of these people may have had diseases that were going to catch up to them very shortly anyhow. So I think there's a lot of deaths being attributed to this that I'm not sure it's always fair to attribute it to that. They in fact may have gone over COVID and then died a month or 2 months or 2 weeks later, even though they recovered, just because it hit their system so hard that now they were that now it hit their heart harder, and now they just couldn't manage with their heart failure, and that's really what did them in. So that's going to probably right now get counted as a COVID death. So statistics can be a little fuzzy here, and we just need to be careful about that right now. As far as the state of Wisconsin is concerned, we have absolutely never had a problem with hospital capacity or ICU capacity. We still don't. There's still plenty of capacity. And you can go to the website at the state level, and you could spend hours there looking, and they have it. It's a great website. They're doing a fantastic job. And as more and more data comes out, for the Department of Health, they keep breaking it down different ways. So many ways that I have to keep going back and say, now where did this information go? Because it used to be on this page, and now they have 4 different pages, right? But you can see the capacity. There's no issue with capacity right now. Aspirus never got close. Basically in the month of April, they had shut down all optional activities so that we could gear up for a surge that thankfully never hit. We've still not really had a surge. Hopefully we don't really have a surge. We have more cases, but I think we have to remember in terms of a surge, we're just trying to fend off healthcare capacity issues at the hospital. Our hospital can normally handle, give or take, 250 active patients at any given time. But I know we're prepared if we needed to during that time to even be able to take 600 patients at once in the hospital and have the facilities, the rooms, the beds in order to do that. I don't foresee that happening in this area. I certainly hope it doesn't happen in this area. That being said, where are we right now today? So look, we still need to be careful. I think we have a very difficult time in the United States. The difference between protecting ourselves and also making sure that we can still operate our economy and get supplies. So it's been very difficult. And I'm not talking about PPE supplies. You hear that a lot. We're doing really pretty well in Wisconsin in this area. Wisconsin Medical Society has actually helped with that and has secured some supplies that organizations can then buy from them at the same rate, no profit, just trying to centralize some activity. But there are parts of the country that are not doing well with that. They do not have good supply chain management from the organizations, and that's an issue. I think supplies are definitely catching up in general, but there are still some management issues that they have there. As far as, if you don't need to do a lot of stuff out, then don't minimize your risk. Where is the safest places to go right now? The safest place to go is actually to a doctor's appointment and to a clinic or to the hospital if you need to go. One, if you think you need to go in to get seen at the emergency room, please go. Okay. If you got a sliver, don't go to the emergency room, not because of COVID, just because you shouldn't go to the emergency room with the sliver. Go to your doctor's office or go to the walk-in, right? But we don't want people waiting, because one of the things that we have seen is some people are waiting to go, and then now they're ending up in the emergency room and they're sicker than they should be, and it's actually more difficult to take care of them just because of how sick they are. They don't have COVID. They've not been near COVID. They haven't been out of their house in like 4 months. They haven't seen a person. So go to your doctor's office. I can say, at least for Aspirus, since that's where I work, you will not get into a doctor's office without being screened with questions, without your temperature being taken. If they suspect that you could be a COVID person at all, then you're turned away. You're told to go to your car, given a number for our COVID hotline to call, and then they screen you and they decide if you can go back in with permission or not. And where. All of our clinics are healthy clinics right now. Our walk-ins will see the COVID patients, especially at Weston and Plaza Drive. And it's possible the other clinics you'll get seen, but you'll get segregated. You're not going to be allowed to stay in the waiting room, so we don't expose anybody else. You're going to go straight into a room then, right now. Could that change if there's a big outbreak? Sure, we will dynamically switch things up. But right now, that's the safest place you can go and get screened. And really, when you look at it, there's not that much out there. The majority of it that's come up have been in smaller groups. In other words, one person caught it from this person, and it's in the household now. Those 6 people that live there have it. So there goes 6 cases right away. So you need to really look at that. So how else do you prevent this? So we go back to virus prevention, and the number 1 rule is hand washing. Hand washing, hand washing, hand washing, right? With soap and water is best. If there's not soap, does water work by itself? The answer is yes. The act of scrubbing your hands with just water will work. So way back when, In microbiology, we did an experiment, so our hands were dirty. We came in, we swabbed our hands, grew out the bacteria in a petri dish. That's how you do things, right? Then what we did is we washed our hands in water. Then we swabbed our hands and put it on a petri dish. Then we did soap and water, petri dish. And then finally we used a scrub brush, petri dish. Okay, the biggest decrease you have, obviously, we have bacteria that live on us and belong living on us, okay? We have staph and strep that live on us all the time, along with Corynebacterium and a whole bunch of others. And most of the time it causes no problem because our largest organ that we have in our body is skin, and it's our biggest defense. Okay, so when you get a cut in your skin, it's the biggest, it's the biggest break in the defense you can get. That doesn't mean you get sick because your white blood cells, your infection-fighting cells do a great job. But the largest decrease you have in bacteria growth is just by washing your hands and even in water. Then there are incremental gains every step of the way. They say, wash your hands for about 20 seconds. If you could do that, that would be great. It's not a really long time to do that. There's a lot of different timing methods out there to figure that out. And now what I read is the next version of Apple Watch software is going to help you time 20 seconds, actually. So, modern technology can even help us with things like that. So that's the best way of prevention, right? Stay apart. I mean, generally in Marathon County, we're already socially distanced, especially compared to cities like New York, Chicago, Milwaukee, Minneapolis. Most of our homes are further apart. I'm originally from Chicago. So there you could reach out of your apartment building and hand something to the person in the next apartment building sometimes. And you knew everything that was going on at your neighbors because you could hear them through the windows. So we don't have that. Well, there are some advantages to that, actually. Yeah, everybody always knew where everybody's kids were because you really couldn't hide very easily, right? But in this case, it helps to be socially distanced here that way. Let's see. One of the questions is in terms of drugs and methods that can treat COVID patients and lessen some of the serious side effects associated with disease. So early treatment is best. There's some data. Data is very hard to come by. Most of the data we have is what we would call anecdotal data. And what anecdotal data means is that a physician has tried something. They may have tried it a number of times on patients, and then they report their experiences. And what's important to look at then is what types of patients, in other words, how sick was the COVID patient? Were they in the ICU? Did they have a breathing tube in them? Were they just in the hospital? Not that that's a minor thing. Were they at home? Probably if somebody's at home, we're honestly not treating them other than symptomatically, maybe an inhaler to help with breathing, such as albuterol. That's a symptomatic treatment. We have nothing to cure COVID. We have nothing to cure the virus. There are no antivirals that we know of that work. We don't have anything, as far as I know, on the drawing board to actually truly cure it. There's been talk about hydroxychloric. When does it work? First, it looked like it worked. Then they said, no, it doesn't work. Then it looks like it works again. So a lot of this really depends upon the population you use it in. And it looks like if you're catching the disease early, there is some efficacy to hydroxychloroquine. If you're waiting till somebody's admitted to the ICU and really struggling and intubated, that's probably not working anymore. Okay, it's a medication that actually works on the immune system, and it's used in a lot of other disease states. The biggest one it's probably used in is lupus. And the concern about this is that if we start using too much of it, that there won't be enough for the people who actually need it for other diseases already. And a matter of fact, in this area in April, there was a shortage of it for those who take it chronically. So we don't want to restrict anybody who has COVID that might be useful to, but we really need good proof. And right now we don't have good proof. There's probably the strongest proof right now maybe of steroids helping. Steroids in general decrease inflammation in the body. So if anybody's ever been on steroids before for a certain problem, it makes all your pain everywhere else go away usually at the same time too. And you wish you could stay on it forever. You can't, because there's downsides to steroids also. So you can't stay on steroids forever. But there is a lot of usefulness to that. There's a lot of theories as to how this disease is acting, but it's acting differently in different people. In some ways, there's some data in the beginning that looked like it was acting more like a high altitude sickness, in fact. If you go hiking up at 8,000 feet and you haven't acclimated, a lot of times you can get fluid overload in your lungs. And part of that is happening with this disease when it's hitting the respiratory system and making people terribly, terribly ill. So there's a lot of data out there. It's very hard. What we really like to do in the medical community is what we call a controlled trial. And that's say, if you had a blood pressure medicine, say, take these people with high blood pressure, put them on this medicine and see what happens. Figure out what dose they need, figure out what the side effects could be, and figure all that out by doing it over 10 or 20,000 people. You can't do that with an illness. It's not quite as easy to do that. It's easy to do with bacteria because you can grow the bacteria. You can put antibiotics on a little disc, and then the bacteria don't grow up to the disc. And you're like, hey, that works. There's a clear zone there, but we don't have that for antivirals the same way. So right now it's a struggle. It's mostly treating the symptoms, and it's what we call supportive care and getting the person through that and hoping that they don't get secondary complications, right? You can get influenza and then get a secondary bacterial pneumonia. Okay, you can get COVID, get a secondary bacterial pneumonia, and the bacterial pneumonia could be what kills you off because now your system's just weaker. So there's a lot of different things. In terms of spread, so it's respiratory droplets. Can the virus live on surfaces? It can, but for limited amounts of time. There's some decent published data. Look, if you're going out shopping, at least the limited number of stores I've been to, they all are providing you with wipes. You might want to just even carry some, yourself, and just wipe off the surface. However, the way all wipes work, even in the clinics, okay, is that you have to honestly allow it to dry. Now, if you put the wipe between you and the surface, then fine, because you've also got something. Gloves are not a good idea. People who are wearing gloves, and when you see them out in stores or fast food restaurants or whatever, not really a good idea because it's the exchange that you're having with people. So really, they should just be washing their hands. So if you're going to wear a glove, you got to wash your gloves. There's no difference, other than it may protect your hands a little bit from getting raw from all the washing. But if you're the person handling the money, that's okay. You're handling the money. They're probably not handling the food. I mean, they may be handing you the bag. That's different, right? You're not going to get COVID from ingesting it. You're not going to get your food and water sources are safe. There's no issue with that at all. There's zero data right now to say that it could be transmitted that way. Everything I'm really telling you comes from the CDC website too. Another great website, although I will say sometimes difficult to find the information you're actually looking for. I usually find what I'm looking for like 3 steps away from where I was and accidentally. As I'm backtracking or something. So they could use a little better organization. It looks like it's organized good, but I don't know. The navigation's not the best right now. You don't need to worry about, like, if you're buying groceries and bringing them home and putting it away, put them away. You don't need to worry about, are you going to catch it that way? Is it going to live on the cardboard box or the plastic container, anything like that? I mean, unless you're really going with your tongue and starting to lick the boxes or something like that, which I'd advise against without COVID, you don't really have a concern with that right now. Can people go see, so another question is, is it safe for older populations to see their grandchildren? So, one of the big things that we're seeing right now is there's definitely an uptick in anxiety and depression. So human beings are social creatures. Now, some of us are more social than others. Some people really are more on their own and loners, and that's okay. To each their own, that's fine, not an issue. But it is taking a toll. So if you can have contact, try for safe contact. if you're in a higher risk group and if you're an older person, particularly if you're not healthy, and this could be tough with little grandkids, it depends upon the age, but stay 6 feet away. Stay at least 6 feet away and wear a mask. Have them wear a mask also, right? Sit in a big circle. I mean, sit in a big circle, you know, hope not in the pouring rain tonight, but sit in a big circle in your driveway. It's easy to do stuff like that, right? Very easy to do stuff like that. People need contact. Nursing homes are a different story. Some of them are doing stuff through the windows, you know, maybe visit through the windows, but talk on your phones is another way to do it. I mean, really with modern technology, FaceTime or Microsoft Teams or free Zoom accounts. I mean, they're really great things, right? They let us do things that we couldn't do years ago. And I would say really take advantage of that technology. It's not like being there. I get it. But it's certainly the next best thing to being there. You know, it's something that each person is going to have to really decide really on their own. There's a question about thoughts on today's comments by the CEO of Pfizer. Optimistic that vaccine will be ready this fall. Well, I don't know. So here's what I can tell you about vaccines. I'm actually head of the vaccine committee for Aspirus in general for all the vaccines. And so I have a lot of contacts in the vaccine world from all the different companies. I will tell you that they're all working on it very, very difficult. They all want to be very, very optimistic. There are some vaccines that are looking encouraging. And any of the ones that are looking encouraging, they're already producing them, even though they don't know that they work. So that if they do end up working, they already have a supply ready to go. If they don't end up working, they'll throw the supply away because it's not going to do anybody any good. And they don't want anybody to get sick from it. I think the technology that's going to work the best is going to be something similar to what we use for the latest shingles vaccine, Shingrix. And that's a combination of a vaccine with what we call an adjuvant. Okay, so a vaccine is usually, in this case, a dead virus or parts of a dead virus, or we replicate parts of that so that your immune system reacts to it. And then the adjuvant is something that makes your immune system react even more to it. Okay, so it's sort of like a built-in booster rocket, if you will. The other types of vaccines that we have are live vaccines. We don't tend to want to use those as much because you can actually get sick from those. There are certain diseases where that's the only type of vaccine that we have, right? And that's why some people, if they're immunosuppressed, aren't allowed to get those vaccines in real life. So the first vaccine, for example, for shingles was that type. It was a live attenuated, which means it's a weakened version of the shingles virus. The newer vaccine that's out now is not. It's a dead vaccine. So even those that are immunosuppressed can get it, although it doesn't have the FDA indication for that, but there are studies that support that. And it uses an adjuvant. And that's why some people react more to this one that we're giving, where they're like, oh, my arm's falling off for 3 days, or, you know, they feel very achy. That just tells you your immune system's really reacting to it. So the odds are that technology is probably going to be the one, but it's hard to know what the timing is going to be and when will they test enough people, how many doses will they have, and who's going to get it first. So the people who are extremely ill in the ICU aren't going to get the vaccine, okay? It's probably not going to help them. What you're going to look at vaccinating is a higher risk population and probably healthcare workers, my guess would be. First, but it depends how many doses are available. The other thing that's going to get complicated, and one of the reasons why we've been trying to knock this down so quickly, is this fall is going to get ugly, particularly into the winter time. So flu season for the Wausau area, generally we hit our peak in February of each year. Now, that being said, there are some years it comes a little earlier and it's Thanksgiving time or December, right? But most time our peak is usually around February. We start getting flu vaccines end of August. So just to give you an idea of how flu works, we ordered our flu vaccines in February. So in February, we need to say how many doses we want, and then the organization, the manufacturers commit us to getting us those vaccines. If we need more after that, it's possible there won't be that much because they also gear up their manufacturing to how many are being ordered. And the difficulty coming up is the overlap between flu and COVID in terms of symptoms. There's a lot of overlap there. So it can be very difficult to tell them apart. I know they're working on one swab so we can swab somebody for flu and COVID at the same time and get a result. Turnaround times are going to be an issue. They're already an issue. So if somebody is a healthcare worker or a hospitalized patient, at Aspirus, we consider them a tier 1 or 2. Or if they're pre-op, we have a pseudo tier 2 for pre-surgery. And those are going to get run probably now at Aspirus. Even that one will get run at Aspirus, and we can turn that around fairly quickly. But the test takes 4 hours to run in the piece of equipment. Like, that's how long it takes everywhere. Okay, that's how long the actual PCR test takes. It's different than an antigen test. Okay, it's different than like a rapid strep test, which is an antigen test. That can go in a couple minutes, but sometimes those are not nearly as accurate, and you will get more false negatives with that. So the PCR test is the best test. For the tier 3 and 4, which are community members, and maybe they were exposed, maybe they're symptomatic, maybe it's contact tracing being done, those for ours are getting sent out either to Mayo or to actually ARUP, which is out in Colorado. And I know that, as an example, we were informed today that they are getting inundated with tests. And instead of the 3 to 5 days, it could be going up to as many as 8 days to get those test results back. I know we get a lot of complaints about people being upset that it's taking so long to get that test back. But the equipment can only process so fast, no matter where. And they have a lot more equipment, right? That's all they do is their laboratory, and they have, I don't know how many 100,000 square feet they have of laboratory space, but you can still only process so many so fast. And you can't just say, well, I'm going to buy another piece of that lab equipment so I can process more. You can say that, but guess what? That lab equipment's not sitting on the shelf. That lab equipment may need to be made, brought in. It's 4 months till that piece of equipment is installed. So there's a lot of things. If anybody goes shopping right now, and I don't mean grocery shopping even, they can't produce appliances, refrigerators, washers, dryers, depending upon if it was in the pipeline. You might be in short supply. There's a lot of businesses who are waiting on parts to fix their own equipment. They can't get the parts. So that's a real issue right now. And where does that come from? Is it came from that we shut everything down. Not that everybody got sick who was making it, that things were preventively shut down. And now it takes time to gear back up. And some of them haven't geared back up. So that's the other issue we're dealing with. And it hits everywhere in the system. I would say, those are the things that we're looking at, and it's going to be very tough when you come into our clinic in the fall, in the spring, or winter, and say, hey, I've got these symptoms, and it may cause a lot of delay, and it may cause, you might have COVID. You need to isolate until we get your tests back, and people aren't going to like that. So anything you can do to prevent getting sick is a big benefit. So it said you wanted to pause, right, Sarah?
Hello, everybody. I just want to double check if anybody has any questions. We've been monitoring that chat as we go and answering them just as Dr. Gordon is going. But if anybody has any questions, we have about 10 minutes left. There is a chat feature on the bottom. Feel free to add in a question or comment if you'd like to. I will ask Dr. Gordon another question about Clorox bleach. Clorox wipes have been shown to wipe this down, to clean your surfaces. How about doing laundry? does laundry clean this? Do I have to do it on hot or cold? Do I have to add a special laundry detergent to anything?
Nothing special. Just do your laundry. No, really, nothing special for laundry. Viruses aren't going to live very well through laundry. Between the flooding, the soap that's in there, the heat, especially if you're drying it. You know, if you dry it with that heat at all, regardless of whether you're washing on cold or warm or hot, depending. I mean, I get it. You know, you don't want to shrink your clothes, and I do my own laundry. So, hey, now don't laugh at that. My wife's happy to do it if I ask her to, but I like doing my own laundry. It's teamwork, right? So you don't have any concern about that. You know, if you clean your surfaces, remember the way these things work is by letting it air dry, right? So you clean it, then you don't use a paper towel to wipe it off the liquid. You're not drenching it, right? You're wiping down the surface, you let it air dry. And what's in the Lysol or the Clorox or whatever denatures the virus and just basically thinks about making the little cell explode, and then it's no more. And so it can't do anything.
All right, we are watching the questions. I don't see any new ones come in. So in closing, Dr. Gordon, what would you like our participants to know about COVID here in Marathon County? What is real versus the TV media that is sometimes scary to watch?
It is. So look, I mean, it's here in Marathon County. It's everywhere. If you're gonna travel somewhere, be careful, right? Wear a mask whenever possible. Minimize your exposure as much as possible. So don't get together in huge groups of people, particularly that you don't know and don't know how well they take care of themselves. Definitely avoid people who you know who are chronically ill and stay a distance away. But that doesn't mean don't check in on those people and don't befriend those people. But it might be, you know, if you're going to go their door, ring their bell, both of you wear a mask, stay 6 feet apart or a little bit further, go sit out in the driveway in a nice day. Or even if you're in their house, it's fine to go sit in their house, sit just a little further apart, right? Most homes you can easily sit that far apart and everything. It's fine if they give you a glass of water or something to drink, you're not going to catch it. You know, you're not going to catch it that way. If you start to get sick and you think it's COVID, if it's a virus, call the COVID hotline. It doesn't mean come in. As a matter of fact, we're going to probably have you not come in if we can prevent that. We do have drive-through testing. You literally sit in your car, a nurse will come out, they'll swab you, and you'll drive off on your way. Weston, actually, the Virus Weston Clinic is a site for that, and we're probably doing probably on average of 60 tests a day. Just drive through there right now. Now, some of those are somebody needs their hip replaced. Before you can have surgery, you got to make sure that you're COVID negative, right? So it's getting done 2 to 4 days before their surgery, and then you can't go out, you can't do anything because we don't want you to get tested and then be at risk, right? So we're trying to prevent everything possible for that. And I think if we can do a good job, that we won't necessarily get humongously impacted here because we're not a high density population. Bigger cities are always going to have a problem. If you see where things are cropping up, you know, it's the bigger cities because of the density of populations. Arizona's that way. Florida is that way. Huge population in Florida. Houston, Texas is, I don't know, it's the 4th or 5th biggest city, right? I think in the country, somewhere up there. That's why they're that way right now. The Dallas-Fort Worth area is that way. It can be that way. But the smaller cities are going to have an easier time. I think the younger people are going to be a little bit more antsy to get out, and you're seeing that a little bit right now. I wouldn't go to a bar. Going to a restaurant, a little different. If you can eat outside, for sure, and it's just your family, a little different, right? If you need to go to Menards, well, they're going to make you wear a mask. Home Depot will not make you wear a mask right now, but I would still say wear a mask, right? It's going to help you protect others, that won't protect you, but the more people that do that, the better off that we are for right now, at least until we come up, if there's a vaccine. Hopefully any vaccine we come up with, they're hoping to be a minimum of 75% effective. The FDA actually set the guideline at 50, but I think everybody really wants it to be 75. But it won't work if not enough people get it. Now we have to have the supply if it's going to be a good vaccine. But even assuming the supply, if it's 75% effective, we need 50 to 60% of the population to get it. And right now, it seems like the population, from what I hear personally and what they're publishing statistically, is against getting a vaccine. So I think that will be a big challenge, because guess what? A vaccine doesn't work if people don't get it. Other questions?
Dr. Gordon, thank you very much. This was a wonderful presentation. United Way was pleased to have you present. I believe we have gotten through all of the questions for tonight. Great. Anybody who is on right now, if you have a private question, we've got one more here. But if you've got a private question that you'd like us to get to Dr. Gordon, you have Lori's email. Lori's the person who sent out the invite tonight in your Outlook calendar. In your email, feel free to email Lori and we'll get you connected with Dr. Gordon after the presentation. One last question or two questions here. Talk about a vaccine. Does the virus mutate? And why do you think people are opposed to that vaccine? We'll answer those two questions and then we'll be done for the evening.
Sure. There's been a little bit of mutation. There has not been a ton as far as we can see. And a mutation is not necessarily bad. A mutation sounds awfully ugly, but sometimes mutations are good, and it can mutate into a less strong virus and a weaker virus, and one that won't make you as ill. So we like good mutations. We don't like bad mutations. There hasn't been a lot of mutation to this virus so far. Will it require a booster? We don't know. We never know that on any of our vaccines. So originally when the chickenpox vaccine came out for kids, we gave it. Then as data went on, it turned out we needed a booster 5 years down the road. If we need a booster, we'll figure it out and we'll booster people. The chickenpox vaccine, as an example, was given in Japan for even 10 years before it came to the United States. We're very picky about our stuff here. And so there was a lot of data there. And after they had it for 10 years, they figured out that they actually needed a booster. So same vaccine. So that time will tell. As far as why are people opposed to vaccines, I don't know. I'm very biased because I'm a physician and I'm a pediatrician and an adult medicine provider, and I love vaccines. And I personally am a bull in a china shop with my patients. So I'm going to my nurse who rooms you is going to tell you you need the vaccine. And if you say no, then I'm going to come in there and be a bull in a china shop. I'm like, look, you need the vaccine. Where's the problem here, right? Vaccines are good. As far as side effects of vaccines, they're very minimal and they're all temporary. Very few people ever get any long-term side effects from vaccines, especially the ones that we have nowadays. I think some people think that vaccines, they think it's some kind of conspiracy, that it's just a way for people to make money. Sure, the pharmaceutical companies make some money on it, but they don't make a fortune of money on it. They make much more money on all the other products. And they take a lot of risk, but they themselves are held not responsible for the risk, because if you have a side effect from a vaccine, it actually goes to a fund, a national fund that would pay out if you truly have a proven side effect vaccine. You can't actually sue a vaccine manufacturer. They have isolated them from that, because otherwise no one would ever manufacture a vaccine. There'd be just way too much risk, and you'd never convince somebody. I don't know. I don't understand why people don't get vaccines. I mean, I have a lot of people. We do have some people who refuse to get vaccines for their kids. And I don't get it, because the diseases we vaccinate against, measles and rubella and diphtheria and tetanus and pertussis and Haemophilus and influenza B, they all are horrible. They're all horrible diseases. Not only can you die from every single one of those, but sometimes it's worse if you live from some of those. I mean, do you want anybody to get polio and be paralyzed if you can prevent it right now? And the answer would be no. I can't imagine anybody would ever wish that. upon their kid. So why wouldn't you give them a vaccine? I have no idea. And the danger is if we don't keep up with the vaccines, okay, then you lose the herd immunity. We are a herd. I know we're humans, but we're still a herd. And if you don't have enough immunity, then the vaccine, the virus will come back in. And we've seen that with measles. And in Minneapolis is where we've seen it the closest, right? We've seen that in the last couple of years. So it's really important that we do that. But most people don't want it, in my opinion, and from what they tell me, most of the things are very irrational arguments. It's very hard to win an argument with somebody who's irrational, though. And so you can't rationally discuss something with somebody who's being irrational about a topic and win. I don't wish anything bad upon anybody, but I'll say, look, your risk is your kid ends up dying. Why wouldn't you take every step possible from that happening? And then and you get into the things. Well, it'll be provided for. One of our residents just saw a kid. Mom said no vaccines. He did the appropriate thing and asked why. Most shocking response I've ever gotten, that I've ever heard. I wasn't in the room, but he said that the mother said, well, that's because God made my child perfect. That's great. As far as I know, no one's perfect. My response there, lucky I wasn't in the room. I've probably been considered rude if I were in the room, but I would have said, then why are you here to begin with? Because if your child's perfect, why do you need to come to the doctor at all? So just by presenting, so that's sometimes the mentality that we're dealing with, and I can't get my head around it, honestly. I can't explain it, but unfortunately we have to deal with it.
Dr. Gordon, thank you for all of your work, especially over the last couple of months, and all of the providers at Aspirus and in Marathon County. We really appreciate your extra time with us and the great discussion tonight. Thank you for everybody joining us. It is 7:02. We are exactly at 1 hour. I really appreciate everybody joining us, your commitment to United Way, your commitment to being safe in Marathon County. So wear a mask, wash your hands, and have a great evening. Thank you, everybody.
Bye-bye.
Goodbye.